In this module, I am going to discuss about neonatal hypoglycemia. Now, what is called as hypoglycemia? Remember, there are so many definitions where different texts will give you different values. But let us take it from World Health Organization, which defines blood glucose of less than 45 milligram per deciliter. This is an important number to be remembered because below this number definitely you have to correct hypoglycemia. That is why this number is important for you to remember. Now, please remember, whenever a baby is hypoglycemic, it is not necessarily the baby will always have some clinical features. Hypoglycemia may also be even asymptomatic also. So that is why always it is important that you should look out for hypoglycemia and treat it proactively rather than waiting for hypoglycemia to manifest with the symptoms which may not occur all the time. That brings us to the topic of screening for hypoglycemia. Not all babies needs to be screened. There are certain group of babies called as at-risk babies, meaning these babies are likely to develop hypoglycemia. That babies you have to screen them. What is this group? This group includes babies having low substrate. Whenever I am talking about low substrate, I am talking about the levels of glycogen, low levels of glycogen. Okay, this group of babies include preterm babies. PT is preterm babies, especially babies less than 35 weeks of gestation. Babies having low birth weight, especially birth weight of less than 2 kg, and babies with IUGR, intrauterine growth restriction. They needs to be screened for hypoglycemia. This is the first group. Second group is a group of relative hyperinsulinemia. Why? Because hyperinsulinemia can lead to hypoglycemia because the action of insulin itself is to decrease the glucose levels in the body. And this group of babies includes big babies or large for gestation age baby, LGA babies. Second important group, which is a commonly asked exam question, is a baby born to diabetic mother, infant of diabetic mother. Very commonly asked exam question. And one more group of babies is babies with RH incompatibility. RH incompatibility babies also are found to have a transient increase in insulin levels after birth, so that's why they need to be screened. The third group of at-risk baby includes a sick baby, which is something like a baby having neonatal sepsis or a baby with birth asphyxia or a baby with hypothermia. Okay, so this group of sick babies also needs to be screened for hypoglycemia. So you have to identify this at-risk babies and you have to screen for hypoglycemia. Generally, remember, hypoglycemia is screened by dipstick measurements. Okay, we take heel prick sample and do the dipstick measurement of glucose. You should also know about the schedule of screening the babies for hypoglycemia. Screening is generally done by a heel prick sample, and the testing is dipstick testing. When to screen is the next thing to be remembered. Screening is usually done at 2 hours after birth, 6 hours, 12 hours, 24 hours, 48 hours, and 72 hours after birth. This is the screening schedule for at-risk babies for hypoglycemia. Okay, right. Now let us discuss about the features of neonatal hypoglycemia. The earliest feature to occur in a baby with hypoglycemia is jitteriness or tremors. Now this word jitteriness may be new for some of you, so I will try to explain it in detail. Jitteriness is something like a tremor-like movement which can even be confused for a seizure. More often than not, we confuse jitteriness for a seizure. So you should know how to differentiate jitteriness from seizures. Remember, jitteriness is something which is stimulus sensitive That means if you just touch the baby itself, the jitteriness can occur. However, seizures are not stimulus sensitive. That is the first distinguishing point. Second thing, during jitteriness, there is no eye deviation, whereas seizures are generally associated with eye deviation. That's the second point of distinction. Third important thing is there are no autonomic changes associated with jitteriness. The autonomic changes would include like sudden change in the respiratory pattern or sudden change in the heart rate like that. That does not occur with jitteriness. However, autonomic changes usually occur in a case of seizure. That is how you differentiate jitteriness from seizures. Okay, right. So the earliest feature is jitteriness or tremors. The other features are a child can be lethargic. The mother can tell you the child is not at all active, or the child can have a weak cry, or the child can have a poor feeding pattern. All these are features of hypoglycemia. Sometimes hypoglycemia can frankly present with seizures. And remember for your exams, hypoglycemia is an important cause of neonatal seizures. Okay, right. And fourth important category of presentation is with autonomic changes. Autonomic changes include sudden changes in the heart rate, HR, that is heart rate, sudden change in the appearance of the baby. For example, sudden pallor or episodes of hypothermia. These are all autonomic manifestation, but generally remember, autonomic manifestations are rare in a newborn when compared to older child or adults, where autonomic manifestation usually accompany hypoglycemia. Right? So that's a distinction which you should be aware of. These are the important features about neonatal hypoglycemia. Having studied about what group of babies are at risk for hypoglycemia and features of hypoglycemia, you should also know about management of hypoglycemia. The management depends on whether the baby is symptomatic or asymptomatic. Remember, symptomatic hypoglycemia is an emergency. It has to be treated immediately with the intravenous administration of 10% dextrose. What is the dose? It is 2 ml per kg. So immediately you need to give an intravenous bolus of 10% dextrose, 2 ml per kg. Followed by that, you have to give a IV dextrose, the same 10% dextrose infusion at the rate of 6 mg per kg per minute. This is the standard management for symptomatic hypoglycemia. Suppose child is asymptomatic. You are screening the baby. At that time, you detected hypoglycemia. How are you going to treat it? This treatment will be decided by the levels of the blood glucose. Okay, we can divide it into two categories: a level less than 20 milligram per deciliter and a level more than 20, that is 20 to 45 milligram per deciliter. Remember, less than 45 milligram per deciliter is what we call hypoglycemia. Let's take the first scenario, that is less than 20 milligram per deciliter of blood sugar. This has to be treated by IV infusion at the rate of 6 mg per kg per minute. If it is above 20 but less than 45 milligram per deciliter, you can give oral feeds. For example, suppose the mother is breastfeeding the baby, you can advise her to give feed once, okay? And then you have to recheck after 30 to 45 minutes. Okay. If it comes to be normal, then you advise the mother to continue giving breastfeeds every 2 hourly or as per the requirements of the baby. However, while rechecking, if it is less than 45 milligram per deciliter, then you have to start IV infusion. Are you able to follow this? So please be very clear about the management of hypoglycemia. If it is a symptomatic hypoglycemia, it is emergency. You have to immediately give an IV bolus of 10% dextrose. If it is asymptomatic, then decide according to the levels. Less than 20, you give an IV dextrose infusion. More than 20, you give oral feeds and then reassess. So this is about management of neonatal hypoglycemia. We now move on to an important condition which is causing neonatal hypoglycemia, and that is infant of a diabetic mother. This is one of the favorite topics for the examiners to ask you questions about. And manifestations is where most of the questions are going to be asked in your exam. The manifestations can be remembered by a very important and easily understandable hypothesis given by Peterson. What does the Peterson hypothesis suggest? All the manifestations in a baby born to diabetic mother starts from the mother itself, where the mother is having hyperglycemia. Due to diabetes, she is having a lot of sugars. Okay? Starts as maternal hypoglycemia. This sugar will go through the placenta, okay, enter into the fetus, causing hyperglycemia or increased sugar in the baby as well. Okay, always remember, whenever sugar level increases inside the fetus, the baby's body will respond by increased secretion of insulin. And this increased secretion of insulin is where all the problems are going to start from. Okay, insulin we all know is an anabolic hormone. Okay, so lot of insulin means lot of anabolism or excess growth. That is why the baby appears to be macrosomic. Okay, or a big baby, or what you also call it as a large for gestation age baby. Now this macrosomic baby can have some issues during the time of delivery. For example, it can result in a difficult delivery or shoulder dystocia. And during the time you are delivering or extracting the baby from the mother, there can be a increased risk of complication like brachial plexus injury, right? Like example, Erb's palsy. And shoulder dystocia itself can be associated with a complication like fractures, okay, especially fractures of the clavicle or common. Okay, so all these are indirect problems occurring due to a big baby. Next, you can remember like this: a big baby is having a big sized heart. Not the entire heart is big, but the septum, the interventricular septum, is bigger in size. Okay, and this is typically described as asymmetrical septal hypertrophy. Okay, asymmetrical septal hypertrophy. Okay, now this asymmetrical septal hypertrophy is like a form of hypertrophic cardiomyopathy. It's not exactly hypertrophic cardiomyopathy because this is only a transient condition, okay, which will resolve after some time after the birth of the baby, right? So this is only a transient condition and cannot be exactly called as a heart defect. Okay, that's a point to be remembered. It's a transient condition. Okay, think like this: whenever the baby is big in size, there is increased demands of the body tissues. Let us talk about oxygen demands. Okay, the body requires lot of oxygen because there is lot of tissue inside the body. Now remember, the oxygen demands are more, then the body has to produce lot of RBCs as well. Why? Because the RBCs are the ones which are going to deliver the oxygen to the tissues. So this condition will be accompanied by polycythemia, which is excess of RBCs. Okay, polycythemia. Yes, this is due to increased oxygen demands because of a big baby. Okay, now whenever there is polycythemia, it means that there is a lot of RBCs in the circulation. So definitely the circulation is not going to be smooth. Instead, it is going to predispose the child to develop thromboembolic manifestations. The next important problem is thromboembolic manifestations. Okay. This is because of polycythemia causing hypercoagulability in the blood and causing thromboembolism as manifestation. The next set of manifestation can be remembered like this. Increased insulin can interfere with surfactant maturation. Okay. Because of interference with surfactant maturation, sometimes the surfactant can remain immature till the time of birth, and this can predispose to the condition called RDS, which is respiratory distress syndrome. Remember, we have studied RDS is a condition of preterm babies, but in a term baby also it can occur if the mother is diabetic. I have just explained you the reason. Okay. Next important problem with this increased insulin is it can also interfere with the gut motility, or impaired gut motility can occur, especially the colon motility is impaired, and this condition is what we call it as lazy left colon syndrome. Lazy left colon syndrome, and this can present like this. The left part of the colon, or the left colon, is not working properly. So what happens? The meconium, which is supposed to come out of the colon, may not come out in the required time. So the baby can present as delayed passage of meconium due to this lazy left colon syndrome. Okay. The next feature to be remembered is increased sugar in the baby. Okay. Increased sugar in the baby is considered to be like a teratogen, and this excess of sugar in the baby itself is implied in the causation of defects of the developing organ, or in other words, this excess sugar in the baby is implicated in the causation of anomalies. A very, very important point to be remembered. Yes. Now, let us look at what are the important anomalies which can occur in a baby born to a diabetic mother. Okay. If they ask you the question, which is the most common system affected, then it is cardiovascular system, or CVS defects. Okay. If they ask you which is the most common heart defect, then your answer is VSD, which is ventricular septal defect. Third question, which is the most common group of anomalies, then it is neural tube defects. This is where there is a slight confusion. Suppose they ask you which is the single most common anomaly in a baby born to diabetic mother, your answer will be VSD. If they ask you which is the most common group of anomalies in a baby born to diabetic mother, the word should be there, group of anomalies. Then as a group, neural tube defect is common. Okay. The next question is, they can ask you like this, most specific heart defect. The most specific heart defect is TGA. What is that? Transposition of great arteries. One more important question, which is the most specific, overall most specific anomaly in a baby born to diabetic mother? Then it is caudal regression syndrome. Okay. Okay. What is this caudal refers to? Caudal means something which is low. It is a lower part of the spine or the spinal cord that will not be developed properly. A typical example is the lowermost parts of the spinal column would be something like the sacrum and the coccyx. The sacrum may not be developed at all. It is called as sacral agenesis, which is a typical example of a caudal regression syndrome. This is clearly explained by this picture, where you can see in this area the part of the sacrum is not even developed at all. This is what we call it as a sacral agenesis. A diagrammatic representation of the same picture can be given like this, where you can see the lower part of the vertebral column is not developed at all. So this is a typical example of sacral agenesis, which is actually a part of caudal regression syndrome. Remember, caudal regression syndromes are the most specific anomaly in a baby born to diabetic mother. So from this particular slide itself, so many questions have been asked in the competitive exam. So it is very, very important that you should know it very thoroughly. One more important set of manifestation is something which happens after birth of the baby. What is going to happen is hypoglycemia. If you can remember, in this module itself, just some time back before I told you that a baby born to diabetic mother is at risk of hypoglycemia. What is the reason? It is simple. After birth, the placenta is cut off. The placenta is cut off. So the sugar coming from the mother is completely cut off. Okay. However, for some time after birth, the insulin level will be high. So that high insulin level will cause hypoglycemia in the baby after birth. Second important problem, they also have increased risk of hypocalcemia as well as increased risk of hypomagnesemia. Okay, and especially you need to remember, because these two conditions, namely hypoglycemia and hypocalcemia, can have a presenting feature as seizure itself. And it's a very commonly asked question. What is the most common metabolic abnormality associated with seizure in a baby born to diabetic mother? Number one answer is hypoglycemia. If hypoglycemia is not given in the option, then you choose hypocalcemia. Right? So this slide summarizes the important manifestations of baby born to diabetic mother. So with this, I am completing the module on neonatal hypoglycemia and infant of diabetic mother.